Hello and welcome back to another marathon of episodes on oncology for the Inquisitive Mind. This week, Michael and Josh are going to tackle speaking in the third person, but also prostate cancer. Michael, good to see you. Short introduction, but we're talking about slightly different trials. Yours will be the M0 castrate resistant prostate cancer setting, and mine will be another metastatic castrate sensitive prostate cancer setting, looking at yet another tablet form. Sorry, my mind's gone blank. This is a great start. Androgen receptor signaling inhibitor or pathway inhibitor. Michael, beautiful eyes as always. How are you?
I'm good, Josh. I'm good. Even though it won't be obvious to our listeners, although it might be because Josh is not as loquacious as he normally is. Has been a bit of a while since we've done one of these recordings, but yes, you're exactly right. We are focusing still on castration-sensitive prostate cancer, and let no one say we are not. Now I'm forgetting the words. We are not thorough in our, that's the word I was looking for. We're not thorough in our bringing of multiple agents for the same indication or to the show. I'm going to
This has been a terrible introduction. Just saying.
It's been an absolutely awful introduction, but hey, audience, you clicked on that link, so quite frankly, you have no one to blame but yourselves. So
Well done.
before we get mired in the muck any further, let's start with ARAMIS. Now, ARAMIS is our third straight study looking at darolutamide, and I will skip over most of the background because you can listen to our previous episode that looked at ARASENS and ARANOTE, two other studies that included darolutamide. But as Josh said, the unique selling point of ARAMIS is that it is a M0 castration sensitive.
Castration.
Yeah, thank you. It is a, I was like, that doesn't sound right. It is an M0 castration resistant prostate cancer cohort that we are looking at, as opposed to a metastatic castration sensitive prostate cancer. Yes, I got that right that time. So basically, you had patients that were randomized 2-to-1 to receive darolutamide and placebo. And the reason they choose placebo is there's not really very much evidence for patients with zero. That's non-metastatic castration-resistant prostate cancer. So it might be locally advanced to lymph nodes, but it certainly hasn't hit bones yet. However, that PSA is continuing to go up and up and up. So you're thinking that, well, ADT is no longer working. There's not enough for me to subject this person to chemotherapy with docetaxel, but what about a hormonal blockade? So patients who were enrolled had to be over 18 years old. They had to have histologically and cytologically confirmed prostate adenocarcinoma. Again, non-metastatic castration-resistant prostate cancer. And the important thing to note here is that this was on conventional imaging. So whole body bone scans, CTs or MRI, no PSMA PETs to be found here. And that is an area of contention. There are emeritus people around the world who think that there's no such thing as EMS prostate cancer, that if we have higher definition scans, such as a PSMA PET scan, you're going to find those metastases. Of course, the authors of this trial contend that M0 is a distinct clinical entity, and so it's worth looking at slightly differently. Patients had to have an ECOG performance status of 0 to 1, and if they had pelvic lymph nodes of less than 2 centimeters in diameter, that was allowed. Obviously, no big bulky lymph nodes. Exclusion criteria, interestingly, the main exclusion criteria I've got written down here in my notes is patients could not have a history of previous seizures. I suspect that's because of the concern of neurological toxicity for this family of androgen receptor inhibitors. Patients were stratified according to the PSA doubling time, less than versus greater than 6 months, and the use of osteoclast targeted therapy at randomization, so bisphosphonates and bone protecting agents, and that was just a yes or no question. The primary endpoint was metastases-free survival. Remember, we're dealing with patients without metastases, so that's appropriate. And secondary endpoints were overall survival, time to pain progression, time to first symptomatic skeletal event, time to first cytotoxic chemotherapy, and there are a bunch of exploratory analyses as well. So straight to the results, sub 5 minutes, Josh, that's not bad. So 15, he's giving me a big thumbs up here. That's great. That's always nice to see. Warms my heart. 1,500 patients were enrolled in this study. And in terms of the primary endpoint, jumping straight into it, the median metastasis-free survival was 40, that's 40 months, compared to 18 months. Don't need to tell you that that's significant, but for what it's worth, hazard ratio 0.41, with a p-value that was infinitesimal, and the benefit was consistent across all subgroups. Perhaps not surprising, on one hand, because we're comparing darolutamide, a very potent, very effective agent, with placebo. Very much not that. But it is interesting as well that there at the same time is such a benefit if the M0 prostate cancer is thought to be, quote unquote, inert, less aggressive, that sort of thing. Because when we see patients with less aggressive phenotypes of a particular disease, the benefit does tend to be attenuated. So a significant benefit for M0 castration-resistant prostate cancer. Secondary endpoints, the overall survival was not reached in either arm, and I could not find an updated results for ARAMIS. That's as far as we got, I think. But the hazard ratio was 0.69. And the important thing to note here is the benefit persisted despite 30% of patients in the placebo arm crossing over to darolutamide. So you've got patients who are getting a similar benefit down the road, but you've got a consistent benefit in the overall survival. I won't belabor the point because it's just going to be a whole bunch of darolutamide is better, but time to pain progression, cytotoxic chemotherapy, symptomatic skeletal events, progression-free survival, PSA progression, initiation of subsequent therapy, all favored darolutamide. And almost all of these hazard ratios are less than 0.5. So we're looking at greater than 50% benefit of darolutamide over placebo.
Can I ask a question?
Of course.
Michael, just while we're riffing, might as well make it longer for you to finish your article as I interject here. Why wouldn't you put overall survival as a primary endpoint here? And it's a good drug. If, let's say, you had no bone metastases and only some lymph nodes, and you could extend that for 10 years on a singular agent, this is a hypothetical scenario, of course, but would overall survival just not be a better primary endpoint than metastases-free survival?
I think you could say that about pretty much any oncology study, Josh, and it's a very valid point. No, I completely
That's why I'm
agree.
asking.
Yeah, I think that in an ideal world, and we talked about this a lot with the breast cancer studies that we did, in an ideal world, yes, overall survival is going to be the primary endpoint because that's the gold standard. That's the pot of gold at the end of the rainbow, whatever other trite metaphors you want to use, is the thing that people care about, doctors and patients alike. But I guess the question is, this is prostate cancer, much like breast cancer. We've got really good agents even after darolutamide. And so perhaps it might be more of a practical thing that you need a surrogate marker for overall survival in order to get the information out and to have the trial conclude in a decent amount of time while it's still relevant. And that's the only reason I can think of, because I don't think there are too many reasons why, if you had the capacity to have overall survival as a primary endpoint, that you wouldn't.
I have a second question. That's a good answer. I know I was a superfluous question.
They're raining down. This is good.
I know. You know I love prostate cancer. It's one of my things. But my other question is this. So this is an M0 study, right? So the definition is you theoretically have no metastases based on conventional imaging of a CT. You know where this is going, a CT and a whole body bone scan. But we have PSMA PETs, and most urologists do a PSMA PET if someone's got a high baseline PSA. And I've heard opinions, and maybe not necessarily my opinion, that if you've got a high PSA at initial diagnosis, I'm not talking about metastatic or presumed localized, you probably actually have metastatic disease, and the PSMA PET will likely pick up a metastasis somewhere. So this cohort of patients, you say some people don't believe in it, some people do. What's your take in the role of PSMA PET in the M0 castrate resistant prostate cancer cohort?
Well, I mean, not that anyone particularly cares, let's be honest.
It's a hard question though, right?
It is a hard question, and I think it does sort of depend on the patient and on the particular situation. And I'm going to sort of be a bit evasive here, but also on the other options that are available. Because let's say, for example, you have a patient with a high and you have, because I think, and correct me if I'm wrong, Josh, but I think the PBS criteria, and this is why I said sort of the system as well, where you're practicing has a influence, that it is no metastases on conventional imaging. I don't remember if it has that specific conventional imaging stipulation.
I'm not sure, but the studies definitely only used conventional imaging.
Yeah, no, absolutely. So the question would be, if you have a patient where, they have a PSA and they have maybe, I don't know, low volume disease, the question becomes if they haven't had a novel anti-androgen before, and that's a vanishingly small group because all of them are being shunted in the castration sensitive space. But if they haven't had a androgen receptor before, I guess it doesn't really matter because of the other options. Like, so if you have M0, basically, and circumstances are that you either don't have access to PSMA PETs or the PSMA PET somehow shows no metastases, then ordinarily under the, and I'm focusing on PBS because it's obviously what we know, but apply this to your local and governmental guidelines. But if you had M0 disease, I don't think you could access any other novel anti-androgens under the PBS, and you're not going to give that sort of person chemo. You're not going to give them docetaxel while they're not metastatic, and particularly, presumably, they won't be particularly symptomatic either. So it's a case of darolutamide compared with nothing. But to your question, if you have a castration-resistant patient with castration-resistant prostate cancer and the urologist does a PSMA PET and it finds one isolated spot, you can still get abiraterone or enzalutamide if they haven't had it previously, and they're still really good drugs. We know that, but I think it's a very niche indication for darolutamide. And I actually asked you this while we were off air, as it were, is how many M0s have you actually seen? Because in my experience, and you have more experience in this area than me, but in my experience, they're not that common with the proliferation of PSMA PETs, but you actually said you've seen quite a few.
Yeah, maybe because I was a very, very high volume center, but yeah, we've seen quite a few, and they're actually looking for studies of when people progress on darolutamide, adding extra drugs to see if you can reverse that resistance. So the question was really mean, and I'm sorry. I'll say that on air, Michael, because I don't think there is an appropriate answer, especially...
There's no appropriate answer, no.
No, especially in Australia where you can only get like 2 PSMA PETs free, and then essentially it's all going to cost you $700 and something like that, and that's a lot of money.
But it is, I think it is down to what makes it a hard question is it's down to the individual patient, what options they have available, and it's down to what information they come to you with. If you're working up this patient and you might not want to burn one of your 2 PSMA PETs on them if you think you can get access to darolutamide. But it's a tricky question, one that doesn't have an answer.
It's a choose your own adventure. Love those.
Very much so. But Josh, that was great interjections there.
Thank you. I'm trying.
Yes, we are trying to do a bit more back and forth, so that's good. But I think we've rambled on a little bit, so why don't we get to yours, which is your study, which is swinging back to the castration-sensitive prostate cancer space with Titan.
It's a great
Titan.
It's a great study, and I think in this case I can make this even shorter than your 5 or 6 minute mark. So Titan 2019, it was first published, Targeted Investigational Treatment Analysis of Novel Anti-Androgen, thus the word Titan. When you look up Titan...
really wanted to call their study Titan, didn't they?
They really did, and when I typed in Titan into Google, it just came up with all this Disney stuff, so, I love that too. So essentially we're looking at apalutamide, which is another anti-androgen. Essentially, it's an oral non-steroidal anti-androgen. It binds directly to the ligand domain of the receptor, blocks androgen receptor translocation, DNA binding, and other fun things. At the point where it was already approved, at this time it was in the non-metastatic castrate-resistant prostate cancer setting, but I feel that's actually only in the US and Europe. I haven't seen that in Australia, but very happy for, to be corrected. So send us an email or a phone call or something. So this was a phase 3 randomized double-blind placebo-controlled multinational trial involving patients with metastatic castrate-sensitive prostate cancer. You had to be castrate-sensitive. You had to have at least one lesion. Of note, high versus low volume was based on the charted protocol, which is 1 visceral metastases or 4 skeletal metastases. They had to have continuous ADT. They were allowed prior docetaxel, and ADT was in less than 6 months. Randomized 1-to-1, with the primary endpoints being overall survival and radiographic progression-free survival, and all those secondary endpoints. So you were allowed to have docetaxel prior, but it was a pretty small group from memory, and that's pretty much it. So if we go to the demographics, they were well balanced. They were all men, as you'd expect, Michael. or
Very hard to get
biologically
prostate
men.
cancer. Yeah, very hard to get prostate cancer without a prostate, but good call on the biological male.
Thank you. I don't want to get in trouble, so apologies, everyone. When it comes to disease volume, 2/3 had high volume disease, which is interesting. So, initial report with the follow up was 22.7 months. I'm already in the results, Michael. So radiographic progression-free survival at 24 months was 68% versus 47%, hazard ratio 0.52. The first interim analysis of OS, overall survival, was already pretty good. So it was 82 versus 73%, favoring apalutamide with a hazard ratio of 0.67. There was ongoing follow-up in this study at that point in time, despite having almost what looks like a positive study. RPFS at that time was positive, and if you go to the subgroup analysis in that forest plot, pretty much everything favored it. Right. There's some exclusions, including baseline visceral metastases, a very small cohort of patients. The other one would be over the age of 75, but that's also a hard group to quantify, I think, as a secondary endpoint. The overall survival I've already spoken to, but the median overall survival was actually not evaluable because they were all still alive. That was quite important to note. Secondary endpoints, time to secondary chemotherapies or cytotoxic chemotherapy, longer in the apalutamide arm, median time to PSA reaching undetectable levels, high in the apalutamide, so 68 versus 28%. And if you look at essentially with most of these, it all favored apalutamide. That's chemotherapy, pain progression, chronic opioid use, skeletal-related events. Mind you, that first analysis, a lot of this stuff wasn't statistically significant, and so it did cross that hazard ratio of 1, but it's just important to note. Median time to PSA progression was definitely much better in apalutamide, hazard ratio of 0.26. Adverse events, because it's APA, so slightly different. Rash was the most common in a quarter of patients. Thyroidism was higher in the apalutamide arm, and ischemic heart disease was about 3 times the risk in the apalutamide arm as well. Moving to 2023, so we've moved forward about 4 or 5 years. The overall survival.
Just before you do, Josh, and you might be coming to this. You mentioned it very briefly, but I did want to ask your opinion on the discrepancy between the percentage of patients that had docetaxel and the majority of patients having high volume disease, where if you can handle it, a lot of people are using sort of triplet therapy now based on previous evidence, but only 11% of patients had docetaxel in the study. How do you think that influences your interpretation? Do you think that it actually improves your assessment of apalutamide, that you're having patients that are quote unquote potentially undertreated and you're still having this great benefit?
Yeah, it's a really, really good question, Michael. I think the first thing to say is that the ARAMIS trial, which was the triplet therapy trial, which proved triplet better than doublet treatment, only came out 2 years ago. So this was published, the first survival was actually published well and truly before that. You can see that median time to progression-free survival or disease was much better in the low volume than the high volume. Median radiographic progression-free survival, if I'm just having a look, that's placebo actually, and it wasn't reached in the high volume disease. So apologies about that, but I do have an answer for you if you want to look at the actual outcomes, Michael. So I can't comment on the inclusion/exclusion specific criteria and why most people didn't have docetaxel, but they're also looking for a novel drug that's probably not a chemotherapy. So in the high volume, the hazard ratio is 0.68. This is overall survival. In the low volume, it was 0.65. Okay. In the metachronous, so that was synchronous. In the metachronous high volume, it was 0.69. And then in the metachronous low volume, it was 0.22, which is where you kind of see that massive difference, right? So you see the metachronous high volume wasn't as efficacious as metachronous low volume. So in today's or today's climate, I'd probably be using triplet therapy for the high volume disease, with the caveat you have to remember that you have to use precision medicine, which means not everyone should have triplet therapy irrespective of it being an option, right? And the other thing is some people hate rashes or pruritus or have ischemic heart disease risk. So you also have to take that into account. So to answer your question, why didn't they have docetaxel? I wonder if it was potentially in the context of this is an upfront trial, meaning you could go on this trial and avoid chemotherapy, right? But you could also have chemotherapy. Who's going to want to have chemotherapy if they can avoid it? That's probably my question to put out to the table.
Very fair enough.
Does that make sense? Yes, no, maybe?
Yes. Yes, no, maybe so. Definitely makes sense. I think it's just something to consider if you're at a place or if you're a clinician that uses a lot of apalutamide. It would be interesting to see what your experience is with
That's it.
triplet apalutamide compared to docetaxel, because we don't get that information from this trial.
Yeah, what's interesting because the triplet is only, I mean, I've only seen triplet used with Darrow, and that's only in the context of that's the study I've seen that sort of came out 2023, I think. I don't know if they use triplet with apalutamide. Personally, I haven't used it, and that's purely because, first comes to the market, maybe that's kind of the thing. Maybe the crossover would be the same, but there's no big phase 3 data that I'm aware of. The other just important side note to make, Michael, is there was crossover. About 30% of patients did crossover. It's somewhere in my notes. Apologies, I can't see it. From placebo to intervention, there was still a benefit. So that's really, really important. Adverse events was high in the high volume group, potentially because of just the disease. So the outstanding issues with this trial, one, the overall survival data I've given to you, sort of the 2023, 2024, was outside the follow-up. So I actually stopped the trial, and there was also analyses post that. So it's hard to kind of interpret that. So yes, while it's definitely better than placebo, we don't have the really strenuous long-term data we see in sort of Enzamet. As an example, my patient that I saw the other week, there was week 500 and something on that trial. So that's kind of my sort of take-home points.
On the plus side,
good job, Michael, having a drink while we're recording. Love that.
I'm thirsty. What can I say? On the plus side, there are lots of questions, and I don't know about you, but apalutamide is definitely the novel anti-androgen that I've seen the least of in my practice. But there's a daily tablet, as opposed to like enzalutamide, for example, which is 4 tablets twice a day or something ridiculous. So that is something to consider if you're considering reducing things like pill burden or financial toxicity, that sort of thing. So that is a plus in apalutamide's favor. But aside,
can I be annoying and say something? I'm pretty sure apalutamide's 4 tablets.
I think
it's 240 milligrams.
I think that there is a daily formulation coming, though. That's something that I've heard. That's something that I've heard for a little while, just sort of in the background. I don't know how close it is, but I think that's going to be a major selling point for APA over some of its competitors, is that it could be coming in a daily tablet. But yeah, not here yet. I guess the final question I had, Josh, before we wrap things up is, can you conceive of a situation where you would use apalutamide over its competitors, assuming that there is no daily formulation?
Yeah, really hard question, Michael. I think I have not used it very often, to be very, very honest with you. Maybe that's just where I've trained and where I've worked. I think I would use it when someone couldn't tolerate another drug. I think it's fine. And I think if you want to not be specific to a drug company, sure, use it. It's approved. It's got evidence to support it, right? So if you want to go 1 week do enzalutamide, the other week do apalutamide, then do abiraterone, then move on to darolutamide, like you do you. I think
would be an interesting single center study, though, right?
Yeah, no, but they'd all have to pay for it, and actually, you could probably get it funded. But anyway, not the point of the trial. What are we doing next week, Michael?
So next week, Josh, we are hurtling along, and we're going to actually stay in the castration-resistant prostate cancer space, and we're going to look at 2 very interesting trials. I will be looking at TALAPRO-2, which is a study we've talked about before, but it's always nice to tread old ground and new ground as well. So I'll be treading the old ground with TALAPRO-2, that's talazoparib, in patients with and without homologous repair deficiency related prostate cancer. And Josh will be talking about PEACE 3, which is the addition of radium-223 to enzalutamide. And unfortunately, no superpowers, Josh. Very disappointing.
No, but peace out, and I'll see you next week.
That was terrible.
Thank you.